I'm Steve Kossor. I'm a licensed psychologist and a certified school psychologist in Pennsylvania. I was licensed in 1981, and I've been working, I was going to say with insurance companies. I actually have been working against insurance companies for about 30-some years. Does anybody in the audience want to work for an insurance company? Just checking. I've never had a single hand go up. And I think that's for a very good reason. So let me just start with the presentation today. I'm going to go through this relatively quickly. I do have some shameless self-promotional literature over on the table there. If you'd like to take the available resources, if you put your email address, please print carefully on the pad over there. I'll be sure to be able to correspond with you about other stuff that you might want to have in your possession as you thwart the insurance industry. All right. I had a really good time at the conference yesterday and then this morning, and I'm struck by one thing just flat out. You guys are nurturing, caring, benevolent, gentle, patient, and competent. That means you're skilled and you're motivated. So with that in mind, thank you for being on the right side of the equation. The other side, on the other hand, exists to restrict or eliminate treatment funding. That's why insurance companies exist. This may have something to do with why none of you want to be part of that organization. They believe in the concept of a mile wide and an inch deep is a good thing. Nobody else believes that. Certainly parents of kids with disabilities don't believe that. But nevertheless, that's the reality. That's what certificates of excellence go up in competitors' practices for, and what politicians get plaques put up in their offices for, because by definition, they're dealing with limited resources that have to be spread as far and wide as possible in order to give as much treatment as possible to all of the children who are entitled to it. And that's what we're going to talk about here. That amounts to driving a tack with a toothpick. Now, if you drive a tack with a sledgehammer, you're overdoing it. There's no question that that's not appropriate. But if you try to drive a tack with a toothpick, what happens? You break a lot of toothpicks and you discard them, and eventually you conclude that the kid couldn't be helped, along with 10,000 others just like him, but you did the best you could with those limited resources, so you get a certificate of excellence and a plaque for your undying service to the community. How do you cope with a system like that, that is so stacked against you as an ethical, competent practitioner? They create barriers. You have to build bridges. That's all there is to it. It's a balancing act. They have their motives, their intentions, their directives, and you have your internal core guiding you to do the best you can for the kids that you're working with. For children with disabilities, regardless of family income, in Pennsylvania and 33 other states, there is a civil right to access to Medicaid EPSDT funding. EPSDT stands for Early and Periodic Screening, Diagnosis, and Treatment. It's a federal program. It started in 1967. It is one of the only federal programs that has never once, not once in 50-some years, ever been cut or significantly impeded. It's like a third rail. Nobody touches EPSDT because it was created in 1967 to save children. The bottom line is the motto for EPSDT is whatever it takes. Because if you're a child and you can have your vision corrected or your hearing corrected or your teeth or other aspects of functioning corrected before you leave childhood, you have a good probability, you know what a trajectory is? It's going to go up and it's going to continue to go up and you're going to benefit society. This is a no-brainer. At least the Congress thought it was a no-brainer in '67, and they've been re-implementing it annually. It's part of the Affordable Care Act. I mean, it's not going away, which is why I gave up my private practice about 30 years ago, where I used to straighten my tie and listen to children lie to me about what's going on in their lives. And their parents are in the waiting room wringing their hands and writing a check. I started a program in 1981 when I got licensed, where I'm supervising unlicensed people who go into the homes and schools of children, and they work with them right there where the problems are happening, and they act in some ways like a force field, repelling some of the more pestilential influences that they're surrounded by in schools, even good schools. So the bottom line is I figured out how to bring the treatment into the lives of these kids and do it funded by Medicaid. You have an absolute civil right to access EPSDT funding if you're enrolled in Medicaid. So how do you get enrolled in Medicaid? Really simple. If you have an IEP, ka-ching, you're enrolled in Medicaid, because every school district in the United States can tap Medicaid if the child has an IEP. Now, it's a little more complicated than that, but the bottom line is every single school district in Pennsylvania and in the world at large that can tap Medicaid for funding does tap Medicaid for funding. If you're a guidance counselor and you see a child who's got an IEP and you talk to the child for an hour, you submit your documentation to the school, and the school packages it and sends it to an organization that builds Medicaid. The Medicaid payment is deposited into an account for your school district, and your school district, as long as they're using it for, quote, special ed purposes, that's not quite well defined, they can tap Medicaid for about 50% of the cost that you invoked because of your service delivery for the school district. Some school districts ran afoul and started billing for services every Thursday like clockwork, even when Thursday is Christmas Day. Oops, it's a mistake. There are places that are making a living ferreting out fraud, waste, and abuse of Medicaid. And well, there should be, because there's no place for that. These are public funds. And unfortunately, that is what ignites the fire under the insurance companies and some state officials as well, some county officials. They're convinced that EPSDT is a terrible mistake, that it's squandering resources that are scarce, and et cetera, et cetera. So they're determined to eliminate access to that funding, and especially so for mental health treatment. Now, why mental health treatment? Well, let's take the idea of hearing. If you have a hearing problem and you get a hearing aid, you don't have a hearing problem anymore. It goes away as a definitive, yes, this helped. In mental health, there really isn't a way to definitively say, this helped, kid's not finished yet, but this obligates the state to continue paying for the treatment services. Well, that's what I'm here to tell you about. I figured out a way to prove that your treatment is actually causing improvement in the life of a child. And if you can show that the treatment's not finished yet, it makes it so, according to the Medicaid rules, that the insurance company cannot stop funding treatment. Cannot. So how do you create the equivalent of a hearing aid that works in mental health? Well, it's relatively simple. We do something called criterion referenced assessment all the time. We've been doing it for hundreds of years in schools. Mrs. Jones creates a test of history for a curriculum thing that she created, and she gives the same test to all of the kids in the class, and some of them do really well, some of them not so well, and some of them do very poorly. But through that means, Mrs. Jones is monitoring how well the kids in her class learned that material, right? We've all experienced this, pop quizzes and whatnot. It's tried, it's true, and it's very well established in the literature as a criterion referenced assessment. All right. There is also norm referenced assessments, which are the IQ tests, the WAIS scores, WICS, the various other ones. They compare the performance of children in your classroom with lots and lots of other children elsewhere who are approximately the same age on a standardized test that somebody else created. In the world of mental health outcome measurement, the only one that anybody recognizes is norm referenced assessment. It's as if criterion referenced assessment doesn't make any sense, and there's a reason for that. You can create a single subject with repeated measures, experimental design. I'm starting to stretch the limits of your awareness about statistics now, I know, but just remember that. Single subject, repeated measures. Very, very simple. It's been used for hundreds of years to measure the output of crops, different seeds planted, compare this one with that one, take a measure every week, see how big the plants are getting, etc. Well, you can apply criterion referenced assessment to a single subject with repeated measures design really easily. You create an assessment, just like you would in Mrs. Jones' class, and the assessment measures the extent to which the child has gotten better in their aberrant behavior. How frequently is Johnny kicking, hitting, spitting, pushing? You have these negative assessments. And you simply measure how frequently and how severely the child's manifesting that behavior this week. It's repeated measures, single subject, right? Who are you asking for that data? This is very important. You may think you're asking the teacher, but now we're going to jump into deep politics, and I'll explain to you that it's okay to ask the teacher, but there's one person you have to ask if you're going to continue to mandate insurance company funding, and that is the parent. Now, parents will often say, how am I supposed to know what he's doing in school? I'm not there, which is a horror, right? Parents should not be disengaged, disenfranchised from their child's school day. And unfortunately, in order to bring them into involvement in the school day, they have to be educated, and frankly, they're not required to be educated, so a lot of them say, go ahead, educate my kid. And they do that. That's a terrible gesture for a parent to make, but unfortunately, they make it. So what we have to do is come up with a way for parents to have a say over what their child's progress has been in school. And it's very simple. I'm going to give you an example of it. We want to compare the performance of one child with the same child's performance on a set schedule every week for several months, using a measure that I created for that particular child. We're going to create a measure that uses interval data, and this is really important, to quantify the differences. Not nominal. We're not just simply counting incidents, 5, 3, 2, whatever. That's bean counting. It's kind of nasty to do to a child. And it's not ordinal data either. In other words, you're not just picking a range, he's good, fair, perfect, or some innocuous kind of a generic assessment of where they fall on a continuum. You have to create interval data, because once you have interval data, you can subject that data to sophisticated statistical analyses, analysis of variance, all kinds of other sophisticated tests which make it possible for you to make reliable and valid statements about the effect of the treatment on that child. You can literally say the child's behavior improved significantly because of the interventions that were delivered to that child. Once you can do that, you can hold those data up in front of an insurance company or an administrative law judge, if need be, and say basically, look, this isn't just an opinion, this is a statistical analysis of data supplied by the parent. Very few insurance companies are going to look a parent in the eye and say, you're a liar. But they'll accuse my staff of being liars. Well, you just want to keep providing those services, keep turning that crank and generating income, so we can't trust anything you people say. And the other side of that coin is that, well, you're right, we do want to make a living, but if we've proven that the kid has gotten better, we have no basis to do this motion, and we'll stop it. But until that child doesn't need our help, we need to keep turning that crank because it's working, and here's the data that shows it. That's the argument I'm making to you. For those of you who are interested in learning more about this, because we've got basically an hour, and I want to leave plenty of time for questions, you can go to the website there, the Institute for Behavior Change. It's an organization I created about 30 years ago to be a training site for new professionals who would like to do the best they can to help children with mental illness symptoms in their homes, schools, and communities. Our work is funded exclusively by Medicaid. We have a little over 100 clients now in 3-4 southeastern Pennsylvania counties. And we've been doing this since '96, so there's a huge database of outcomes. And I'd be happy to help anybody understand what those outcomes can be used for and how you can collect comparable outcomes yourself and put them to good use. This is not an endorsement. This is a letter from the Centers for Medicare and Medicaid Services. They don't endorse people or programs, things like that, but you can think of this as an acknowledgement. This is a letter that was sent to my, at that time, U.S. representative. And it says in the highlighted section, we agree that Mr. Kossor has a great deal of expertise and is a passionate supporter of EPSDT. So they recognize that I'm telling the truth here, and I've been presenting this information all over the place for a long time. EPSDT, as I said before, was started in 1967, and it was created for children under 21 years of age to provide treatment and prevention services, and prevention is actually the #1 purpose of EPSDT funding. It provides funding for physical, speech, and related therapies, hearing services, eye exams, eyeglasses, durable medical equipment, home, residential, and inpatient care, dental care, and other services, including mental health care. It literally is the greatest treatment funding secret ever concealed. I wrote a book that describes all the ways that you can access the EPSDT cornucopia. Access to the EPSDT funding is based on one concept, and this is true in every state in the nation. Is the treatment medically necessary? Now, in Pennsylvania, the definition of medically necessary treatment is unique, and there's a different definition in every state. Pennsylvania's was actually recognized by a couple of different advocacy organizations as the one with the greatest fidelity to the federal EPSDT standard. And in Pennsylvania, a service or treatment is medically necessary if it prevents the worsening of the child's condition, or it treats the child's disabling condition, or it maintains the child's functioning at a level comparable to other children of the same age. Any one of those justifies the continuation of EPSDT funding for all of those purposes on that list I just showed you. In order to get access to EPSDT funding, you have to prescribe the treatment correctly, and there are ways of doing it ineptly that a lot of people do. For example, you can't prescribe treatment 3 hours a week. Where? In school, in home. You need to say where it's going to be. And you need to describe specifically what they're going to do. And those services they're going to provide have to be called what we call covered services under EPSDT. So you have to know what you're doing, and the average pediatrician just doesn't know. The average psychiatrist doesn't know how to prescribe EPSDT-funded treatment. They would if they could, and I can explain it to them. It's not hard. But you have to say what you're giving, where it's going to be delivered, how many hours per week, what's the start date, what's the end date. You have to lay it out in explicit detail so that the reviewer at the insurance company can go, we have to pay this. That's your goal. You want to build a bridge over the barrier of, nah, we're not funding this. Then it has to be delivered correctly. And that's what I'm going to describe a little bit later about how we've come up with a way to deliver it correctly so that we don't have to pay the money back. I've been doing this for 30 years, and I think in the entire time I've been doing this, I don't know offhand, I never did the math to figure out how many dollars we had to pay back because a report that we put into the filing cabinet slipped between 2 folders. You've seen that? Okay, it wasn't there when they went to the cabinet. Wait a minute, here it is. But you can't do that. You can't show it to them after the fact. So we have these things where the insurance companies come loaded for bear because I'm billing 30 and 35 and sometimes even more hours of treatment every week, intensive individualized treatment for children for a long time. 90% of the kids that I've treated are finished in 3 years or less. So it's not like I'm turning a crank and just indiscriminately making money. But I am helping kids. 75 to 85% of the kids we work with begin to make significant progress in 4 months or less. And we can prove it. And that makes us very different from everybody else who's doing this. And not for lack of trying. I do try to make this available to anybody who would like to access it. Most of the things that I've created are available up on the internet. There are a couple of books over there you can take with you if you want. When I say it's delivered correctly, you have to have treatment outcome measurement built into the system. And that's not your staff saying, we did a good job, we did a good job, we did a good, yeah, come on. You have to dig deeper than that. As I said before, the data has to be from the parent, not just the treatment provider. So it's helpful to get the data from the treatment provider, certainly. I mean, we should be collecting it ourselves, but not in a vacuum. So when you combine provider-collected data with parent-produced data every single week, after week after week, measuring the child's progress in treatment, you've created a single subject with repeated measures, experimental design, and I'm going to show you how I created you can call it a Likert scale, it's a little more elaborate than that, but it's a measurement system using interval data that you can then analyze using analysis of variance and other statistical techniques to literally say, this child got significantly better because of the treatment they received, period. We talk all the time about evidence-based programs. It goes without saying, if you're not using evidence-based programs, practices, you're kind of behind, in kind of Neanderthal level of, it works because I said it works. This is like, the reason kids are autistic is their mothers are refrigerators. Stop it, come on. That same kind of misguided egomaniacal misunderstanding of reality exists in the psychology profession. And what you'll find is that in this field, for every expert, there's an equal and opposite expert, for better or worse. But if you talk to somebody who understands statistics and how to deal with insurance companies, they're going to tell you weekly data collection from the parent using a reliable and valid means of data collection is the gold standard. You need to have a problem-solving emphasis, not just creating data based on behavior. You've heard of ABC, antecedent behavior consequence. This is like the pinnacle, the greatest level of achievement for people with BCBA tattooed on their foreheads, right? We're going to do evidence-based practices. We're going to move alphabet blocks around, and we're going to get paid for the work we're doing 4 hours a week. Let me tell you about 4 hours a week. That may be the standard that exists in the professional community of people providing treatment for kids with autism disorders or other conditions. But the National Academy of Sciences chartered 150 years ago to advise Congress on matters of science. In writing in 2001 said that a child with autism symptoms, and that applies to lots of kids with ADHD as well, a child with that symptom configuration needs a minimum of 25 hours of intensive individualized treatment every week in order to have a reasonable probability of getting better. Period. In writing, 2001. The American Academy of Pediatrics twice, in 2007 and 2012, said the exact same thing. So if 25 is the minimum, where on earth did the BCBA folks and the state officials and the county officials and the insurance company people say 10's enough or 5's enough? Where the hell does that come from? We talk about turning a crank to make a living. That's what they're doing. They're spreading it a mile wide and an inch deep so everybody gets something. Nobody ever gets enough to get better, and that's the way it works. Or you can follow national standards, you can implement a treatment program, collect data, and prove that this kid is getting better. He needs 25 or 30 hours of treatment a week, every week, year-round, and it'll take 3 years for him to stop being autistic. We've actually worked with kids who are not autistic anymore because they had a terrific level of support. It is possible, I can swear to it, to bring kids off the autism spectrum. Not every kid, certainly, and it's not by any means a common event. But in my opinion, if you have a treatment program that enters the child's life at home, school, community, 25 or more hours a week, every week, year-round, for 2 years, that child cannot possibly fail to make gains. In fact, 80% of them are going to make gains in 4 months, and they're going to continue to make gains. These are data that were interpreted by the University of North Carolina, Chapel Hill, Thomas Jefferson University, Immaculata University. They studied the data we collected, and they all said, wow, you should publish this. Okay, sure. Can you tell it's been published? Have you ever heard of it? Of course not, because it's criterion referenced measures that everybody knows is not reliable, not valid. It's numerical or nominal or ordinal data, and that's what they do to it. I'm telling you, I've created a system that uses interval data that you can actually do analysis of variance and these other sophisticated statistical tests. You can do it, I promise. So in any case, I talked about you're going to do a problem-solving emphasis, not just behavior. Think of this. This is the latest thing I'm working on. You can think of a child as like a cafeteria tray. It's a lousy analogy, but wait for it. On the cafeteria tray, there are some marbles rolling around. Those are behavior problems, but they are quantum behavior problems. They pop into existence and then they disappear. And the people who live on that tray, making their living, picking up marbles and trying to address behavior, have no idea that the reason those behavior marbles pop into existence is because of what's under the tray, what the tray sits on. These are skills like the ability to wait, to delay, to be patient, to screen unwanted stimuli when it's too much, to just simply close your eyes when it's too bright or whatever. These are underlying skills that the tray sits on. And if you can get at that stuff, the behavior marbles stop popping into existence all by themselves. This is the quantum theory of behavioral treatment. It's nothing grand, it's nothing elegant, but it's a different way of looking at a child who's got a behavior problem. You guys are nurturing, benevolent, kind, patient, long-suffering. You're doing everything you can to try to help this kid's tray move through life. Well, so am I. And if I come into that child's life and act a little like this force field in your classroom, that frees you up enormously to continue your good work with the other 29 kids in the room, right? Because this one's taken care of by somebody providing therapeutic staff support, TSS. Now, TSS has got a terrible black eye because, frankly, there were a number of people, and there still are, unfortunately, who are making a living doing this. Right? You've seen this? That's an obscenity. It is, in fact, Medicaid fraud. Period. So why don't people report those characters and say, get them the hell out of my class? This is obscene. Well, the parents are going to go ballistic because you're a teacher and how dare you meddle into mental health treatment, so that cuts you off as a legitimate reporter of that stuff. The schools don't want to buy the argument that'll inevitably come about. The agencies are making a living doing it, so they're not going to report it. Guess what happens when my staff call the Attorney General's office and say, hey, listen, Bob's been in here sleeping for the last 3 weeks. We haven't made a recording of it, but we've been documenting it. You know, have a visit to Bob's office and help them understand that this isn't really a good thing. Who's the first outfit that they investigate? Mine. And they come loaded for bear sometimes, and they leave with rabbit or a mouse because we're not criminals. But lousy TSS persist. What I'm trying to get across to you is this. School districts can create their own TSS program in their own school. They can bill Medicaid. The new IBHS regulations that are being developed by the Department of Human Services will continue to allow schools to enroll in Medicaid and be providers of what we now call BHRS, Behavioral Health Rehabilitation Services. Eventually they're going to call them IBHS, Intensive Behavioral Health Services. They're going to require me to get a license from the Department of Human Services, and in addition to the license I already have as a psychologist. Wait for it. This hasn't broken yet. Physicians, psychiatrists, who are licensed mental health practitioners, just like I am, are also going to have to get a license from the Department of Human Services so that they can bill medical assistance, or rather can continue to bill medical assistance. Why are they doing this? You know, you can imagine why. It's a power grab. It's a way of controlling things. I actually filed a civil rights complaint against Pennsylvania and all of the managed care companies in it about 5 years ago, saying that they were obstructing the access of children with disabilities to get EPSDT funded treatment. They are, that's what they do. And it took 3 years for the state to get to the bottom of this, and like, what in the hell are we going to do? And one of the state officials went in writing, and they even identified him at the Department of Justice by name, gave me his address and phone number. And that individual said that the only reason, one and only reason, for any of these kids getting EPSDT funded BHRS was to prevent institutionalization. That's it. Does that seem surprising to anybody? When the state in writing says that medically necessary treatment is to prevent the worsening, to treat the condition, or to maintain functioning. Where do you hear institutionalization? But nevertheless, that's what he testified to federal investigators. 9 days after I filed the appeal, there was a sea change. No change in policy. The bottom line is, if you're honest, you can expect to be put under a microscope and held up to scrutiny. That shouldn't be a deterrent for honest people. If you're honest and you work for a school district and you'd like to help children to this extent, you can do it. You're going to get some heat, but if you're honest, you can withstand it. I have, so far. I don't have a license from the DHS yet to do IBHS, but I'm hopeful. So the bottom line is you want to have a problem-solving emphasis, not just chasing behavior. And finally, you want to use ABA, that's Applied Behavior Analysis, and full fidelity wraparound technology. It's important to do those two things. Now let me talk about wraparound. Wraparound is not a replacement for treatment. Some people think it is, and they're mistaken. I was a national advisor to the National Wraparound Initiative, and for lack of a better explanation, I finally said, I can't do this anymore because lots of people think that wraparound is a replacement for mental health treatment. It's not. If you don't put mental health treatment in the wraparound cup, it's empty. You can wear it for a hat for all the good it's going to do. And that's why I don't belong to the National Wraparound Initiative any longer. One of the things I want you to take home with you today is the idea that Medicaid is a keg with two taps, EPSDT specifically. You have this enormous pipe going out the back of the Medicaid EPSDT keg into the schools. They can bill for Medicaid and there's no managed care, and it's, it does whatever it does. It's good money if you can get it. But there's also this little spigot coming out of the top of the keg that a parent can operate and deliver EPSDT funding into the life of their own child, in the home, in the school, in the community, for the benefit of that child. So when you have a kid who's really, really tier 3 or even tier 2, and he's making the paint come off the walls with his screaming, you need to intervene. You've got to do more than toothpick treatment. You need wraparound. You need a big investment in that kid's life. And when you do that and you fund it through Medicaid, it's free. Doesn't cost the parent anything, doesn't cost the school anything. There's not even liability for the school unless the school itself is providing the wraparound program. So what I'm arguing is, if you can find a reputable provider of EPSDT-funded BHRS and make friends and work with them in the school, there's no better way of delivering excellent mental health treatment to children. That's a truism. The very next best alternative is to create that kind of an honest organization within your school and bill Medicaid. And of course, you're going to have to get a license with the Department of Human Services at some point. Maybe not. There's a House resolution, number 193, that's up. The House of Representatives in Pennsylvania actually has a resolution that they just passed. And it's saying there aren't enough people providing mental health treatment in this state. We need to find out what's wrong with this and what's going on and what can we do to fix it. Well, stop DHS from requiring me to get another license. That'll help. Don't tell psychiatrists and medical doctors and schools that they have to get a license from DHS in order to continue doing what they've been doing for 20 years. There are other ways to police the system other than making me get a license. Well, in any case, the legislature will hear about that eventually. Check this out. This is very important. In December of 2009, John Tomasini, who was at that time the director of the Bureau of Special Education in the Department of Education, got a memo from Lisa Allen, who's still in that position today. And Lisa told Thomas, quote, "The health-related services a student receives through the School-Based Access Program are separate and apart from the MA services a child receives outside of the school setting." Ooh. And moreover, additionally, there is no cap or limit on the total amount of money that may be paid by the MA program for School-Based Access Program services or MA services that the MA-eligible child may receive. Keg with two taps. What comes out the top spigot has no bearing whatsoever on the pipe feeding the school. I put BHRS in a wraparound cup. BHRS, Behavioral Health Rehabilitation Services, is, in my opinion, the only way to deliver mental health treatment to children that is going to work. In fact, we've proven that it works for 30 years. If you put it in a wraparound cup, what you mean by that is that the services wrap around the child. The parents are involved, certainly, but so's the school, so's the pediatrician, the OT, the PT, the speech people, the others, the one who does hippotherapy, he goes horseback riding. They all get involved in the treatment program. We talk to the pediatrician, and that's sometimes when the pediatrician first learns that, well, the kid's getting ADHD medicine from this doctor and from this doctor. It's not a good idea. It's called polypharmacy. It's a bad idea. But the pediatrician had no idea that it was happening. The parent wasn't malicious and evil. They were doing the best they could with what they had available, and they were actually probably not helping the situation. So by using a wraparound approach, we can get people involved in a kid's treatment program at a level that they could not possibly be otherwise. And in that sense, it creates effective treatment in a wraparound cup. Now, this is a quick little diagram of what could be done right now. A physician is a type 31 provider, and they can bill for 548, 549, 559, et cetera. There are services that physicians can bill for. The TSS service is one of them, as is mobile therapy and behavior specialist services. So the physician can supervise effectively an unlimited number of master's level BSc providers, and each one of those BSc providers can supervise up to 9 full-time equivalents, right? That's 30, 40 hours a week. That's 360 hours of TSS work per supervisor, all under the scope of practice of a physician or a psychologist. This exists currently, and I would be happy to help any pediatrician who wants to implement something like this, and maybe argue against having to get a license from the Department of Human Services to continue doing this good work. Each pediatrician can supervise literally an unlimited number of master's level mental health professionals. In psychology, I can supervise up to 3. So there's a limit on the number that I can supervise, but I'm not a physician. This is a quick little graph that shows the effect of TSS. The vertical black line shows when the TSS was implemented. And you can just see right off the bat, look at the purple one for non-compliance with prompts. Drop TSS in and the behavior stabilizes. It starts to become less problematic. Same with socialization deficits and same with physical aggression. This is representative of what typically happens. Just depositing a TSS into a kid's life doesn't produce this kind of change. The TSS has to be supervised and trained. They have to know what they're doing, and they have to do it consistently and conscientiously. But even when they have all of those attributes, it takes a little bit of time for the child to adjust to it, and you don't see what's called a honeymoon period with TSS. Or if you do, it's a very short period of time. Very rapidly, the TSS forms a relationship, rapport with the child, and then the child begins to want to please the TSS. This is the very basis of treatment, whether it's a psychiatrist, psychologist, TSS, or any other mental health treatment professional. You have to find rapport with the child. Well, TSS, because they're there 20, 25, 30, 35 hours a week, they're going to form rapport more rapidly than somebody seeing a kid once a week. So you're going to see change in a relatively short time after the TSS begins, and over time it's going to continue to get better. These are some studies, the University of North Carolina at Chapel Hill, Thomas Jefferson University. Basically, Thomas Jefferson looked at 887 treatment programs. More than 3/4 significantly improved or stabilized in 1 year or less. North Carolina said 68% overall success in 13 weeks. So we're seeing evidence that this actually has a positive impact. In 2012, we actually showed that of the 53 treatment plans that were studied, the average treatment term was 1.4 years. 90% completed it in 3 years or less. The treatment program was done. There was no difference between ASD, ADHD, other diagnoses, ages, genders, or ethnicity. And each of the treatment populations had a probability of chance of less than 1 in 100 that the physical aggression, lack of environmental safety, non-compliance with adults, communication deficits, and socialization deficits improved due to chance. The kids are getting better. We can show it. It's happening. Overall improvement in all categories was true, with a probability of the results attributable to chance less than 1 in 10,000. That's a colossal level of reliability. Race, gender, family income all made no difference. Kids were getting better left and right. Children with autism, ADHD, and impulse control disorders had the greatest improvements. BHRS was not helpful if very low levels were delivered. And the take-home message is obviously you can't drive a tack with a toothpick. So let me go into, in the time we have left, I want to go into the Kossor scale, which is in that little blue book over there. I'll be happy to send you a PDF version if you want to use that and be able to hit the links. But you can see up here, in the very top, you have a scale up here that measures the frequency of behavior. And we're not talking about nominal, bean counting, or abstract levels in an ordinal scale. Look at this. You get a 0 or a 1. A 0 means it's non-existent. The behavior occurs 0. There's absolutely none of it. Or virtually non-existent, less than once in a month and not worrisome. Okay. A 2 is the upper limit of normal or tolerable for a child in the same age group. A 3 or a 4. A 3 is a few times in the past week and almost every week in the past month. A 4 is a few times in the past week and every single week. You hear the difference? A 5 is many times in the past week and almost every week in the past month. A 6 is many times in the past week and every single week in the past month. We're creating intervals. You can't be a 6 if you're a 5. You can't be a 4 if you're a 3. It's one or the other. And that's what makes this scale an interval scale and makes it possible for you to subject it to statistical analyses and prove that the kid's getting better. We also have a severity rating scale. In the same way, a 0 or a 1, the behavior is not worrisome. There are 0, literally 0, or almost no negative consequences imaginable. A 2 is the upper limit of normal or tolerable for a kid that age. A 3 is the child's behavior is severe enough to worry you almost every time, that's a 3, or every single time. It's severe enough to worry you. If you look at a 5 or a 6, it's very serious. There's a difference between enough to worry you and very serious. A 7 is alarmingly serious, and parents can very readily come to terms with what's alarmingly serious. And then, of course, you get into the 9, 10, it's catastrophic. A 10 is somebody went to the hospital. A 9 is somebody went to the doctor's office. Okay, they're a difference. And once you can establish those intervals so that they don't overlap, you have a reliable and valid scale. That's the Kossor scale for treatment outcome measurement. And I can go through examples of how we record the data. It's in the blue book over there, but what I thought we could do in the time remaining is I can answer questions.
What's the youngest age of child that you work with?
The question is, what is the youngest age of a child I've worked with? The youngest one I've ever worked with was 16 months old. Yeah, the doctor at the insurance company says, well, it says here he cries. They all cry. And I said, well, doctor, I don't know, maybe you weren't this way, but when you were 16 months old, I betcha you were talking to. What do you think? He's not.
Do you find that families that have IFSPs can also get Medicaid through this?
Yes, they can. There's a myth floating around that if you have an IFSP, an individual family service plan, that you're ineligible for EPSDT. Read the law. Birth to 21. Birth to 21. Whether or not the services are funded through any other plan. That's the law. That's in writing, federal law.
The TSS in our county are a lot of times 6-month waiting lists or more.
There's no question that that is happening. And there's also no question that it's flat out inappropriate. The federal statute says 60 days from the day you're diagnosed as having a need for this treatment. 60 days later, or within 60 days, by law, federal law, it has to begin by a competently trained, qualified practitioner. So what do we do with county governments that say, I don't know, we don't have any practitioners? Well, how about somebody says, well, start paying worthwhile wages. The last time they adjusted wages was 1996. That's 27 years without a cost of living increase. I'm paying staff today what I paid them in 96 because that's the most I can afford to pay. But fortunately, I have people who are in master's degrees programs and they're learning how to be licensed professionals someday, and in the meantime, they're making $16 an hour doing TSS work. That's the bulk of my employees, and I'm not in Lancaster County. So the bottom line is, There are agencies who could hire more than enough staff if only they could afford it. A school is an entity that can enroll in Medicaid as a service provider. Absolutely. And your school district is probably one of them that's already enrolled. But a lot of them got really scared when there were a number of scandals about EPSDT funding being clawed back by the state and various other authorities. $20 million in New Jersey in a single year. Well, if you bill inappropriately and you don't document correctly, yeah, you're at risk for having a clawback. So do it right. It's not that hard. If a school district would like to do this, I would be happy to help them do it. I've been doing it for 30 years. I do it very well, very honestly. It's not hard to do right. The hardest part is coming up with the funding for the staff. But guess what? Schools, we're talking deep pockets here. They can pull out of this pocket and pay them with that. They can pull out of this pocket and pay it with that. These are kids who are going to be out of district because they're so difficult to manage. Why wouldn't the school district reach deep and pay with those funds as well as Medicaid funds? And now you have blended or braided funding to bring these kinds of services into the lives of the kids who truly need them. It's doable. It's being done. So far. But when the schools have to get a license from DHS, it's anybody's guess what's going to happen. We can hope for the best, right?
The studies that you did, the research that you did, was it based strictly on autism spectrum disorder?
No. The question was, the studies that I was citing here, do they relate only to autism spectrum disorders? In fact, they don't. We had children with autism, ADHD, and other diagnoses as well. We had children, I forget the age range. The average treatment term was 1.4 years. Some of them were in treatment for just 1 month. That's all they needed. Another was in treatment for 59 months. That's almost 6 years. So we have the range, the gamut. But the beautiful thing about it is what the Thomas Jefferson study and the University of North Carolina study, and these are, again, ADHD, ASD, the entire gamut of kids getting treatment, they found that regardless of age, gender, ethnicity, poverty level, the kids are getting better with an intensive, individualized level of care, 75% of the time at least, and the gains are starting to show up in 4 months or less. We're in the process of conducting more sophisticated studies now. I've got my latest addition to the Kossor scale is an actual instrument. It's a 2-page thing, front and back. Here's the scale for frequency. Here's the scale for severity. You laminate it, you give it to the parent, and you say, okay, Mrs. Jones, last week you scored a 4 for aggression, defined as, and you have it laid out. What was it in the past week? Well, I don't know. Well, did it get better? No, it's about the same. Well, then it'd be a 4 again. So you have this conversation with parents, and within a couple of weeks, they're able to nail it. No, it's not a 4, it's a 3. No, it's not a 4, it's a 5. Reliable, valid, that's the gold standard for statistical research. Yeah.
So my next question is, was the intervention always ABA?
Yeah. Let me explain what ABA is. ABA is like, everybody's definition's a little different. According to Bayer, Wolf, and Risley, applied behavior analysis, these are the guys who coined the term in the late 50s, early 60s. Applied behavior analysis is simply this. You write a treatment program, you take data every week, and the data informs you about what you're going to do next week because you're monitoring it in a living kind of a way. And You're producing outcomes of social significance. You're not just measuring table taps or idiotic things like that. So that's ABA, according to the guys who wrote the book, literally about ABA. There's a journal called the Journal of Applied Behavior Analysis that's been in existence since the early 1960s. ABA is nothing new. And the people with BCBA tattooed on their foreheads, sometimes their heads are too big to get through the door, you know, and they don't realize that ABA fills a small pamphlet. It's not something that's hard to lift. You just have to believe that what you're doing has value to the child who you're treating. You respect the feedback loop, and you let the feedback loop tell you what needs to be done. That's applied behavior analysis.
So there might be some other interventions that are part of that.
Well, you got to be careful because the state created a definition of applied behavior analysis a few years ago that includes feeding, dressing, and various other activities of daily living. I'm sorry, they can do it, they're the state, but that has nothing to do with behavioral treatment. Those are activities of daily living that you can use applied behavior analysis to teach, but I have a problem with calling that behavioral treatment fundable under EPSDT. But wait, it is. They're doing it. They've been doing it for years. So EPSDT is this enormous thing. You can drive a bus through it. It can be used for good or ill. You know, the sleeping TSS are getting paid by EPSDT funding. What are you going to do? You do the best you can with what you got. So thank you for having me come here and talk.